Welcome to This Explainer. Today, we're diving into a high-stakes medical mystery, how the latest 2025 and 2026 guidelines have completely flipped the script on emergency trauma care. If you follow trauma protocols, you know that managing catastrophic bleeding is a literal race against time. But the science behind how we actually win that race, it's evolving incredibly fast. We are seeing major groundbreaking updates in damage control surgery and damage control resuscitation that are fundamentally rewriting the textbooks. You might think the answer is obvious. I mean, for decades, it's been drilled into every single medical professional from day one. Airway, airway, airway. But hold on, because recent data has fundamentally changed the very first steps a doctor takes when the clock is ticking and a life is on the line.
Here is our clinical roadmap for today. We'll cover the XABCDEs of trauma, why we prioritize physiology over anatomy, break down the lethal diamond, look at damage control resuscitation updates, and finally explore expanding balanced resuscitation. Let's get right into it.
Section 1. The XABCDEs of trauma, a new priority.
Starting right with those crucial first seconds a patient arrives, there is a stark contrast between the old and new protocols. The new 11th edition of the Advanced Trauma Life Support Guidelines, rolling out for 2025 and 2026, tells us that controlling catastrophic external bleeding now officially takes priority over checking the airway. That classic ABCDE sequence? It's officially updated to XABCDE, where that lowercase x stands for exsanguinating hemorrhage. This isn't just a minor tweak, you guys. It's a massive paradigm shift. It acknowledges hard data from both civilian and military settings, proving that uncontrolled bleeding is the absolute leading cause of preventable trauma death. Simply put, if you don't stop the leak, a perfect airway isn't going to save them.
So to stop that leak, we rely on immediate, high-yield actions right on the scene. Doing this prevents a patient's physiologic reserves from literally draining away before they even reach the hospital. We're talking about properly applied tourniquets, aggressive hemostatic wound packing, and securing pelvic binders. These are now the absolute first line of defense. By the time a patient hits the trauma bay, these steps have to be locked down so the medical team can safely address the rest of the alphabet.
Moving on to Section 2. Physiology over anatomy, the core of DCS.
This exact concept completely changed the surgical mindset and gave birth to modern damage control surgery. For a really long time, the traditional approach to traumatic injuries was to attempt a definitive operative repair right away. The mindset was anatomy first. You find the damage and you meticulously fix the anatomy. But there was a huge problem. Surgeons realized patients were dying on the operating table despite having perfect surgical repairs. They were dying from progressive physiologic decline. Today, the shift is strictly physiology first. Instead of spending hours doing a definitive, perfect anatomic repair while the patient bleeds out and their body temperature plummets, surgeons now perform a drastically shortened operation purely to stabilize the physiology, stop the hemorrhage, contain the contamination, and get out of there.
Damage control surgery is basically a three-part playbook that makes this all possible. Phase 1 is that rapid, abbreviated initial operation focused solely on hemorrhage control, aiming for under 60 minutes. Then comes Phase 2, where you send them straight to the ICU to aggressively resuscitate and restore their physiology. You only jump into Phase 3, the definitive reconstruction and final anatomic repairs, days later, once the patient is actually metabolically strong enough to survive a long surgery.
Now, a temporary open abdomen might look incredibly intense, but leaving the abdomen open during Phase 2 is a vital, life-saving tactic. By using a vacuum-type closure system, surgeons prevent dangerous pressure buildups known as abdominal compartment syndrome while the body heals and swells up in the ICU. It is the ultimate embodiment of accepting a temporary anatomical measure just to ensure physiological survival. But why do we have to pause the surgery in the first place? What exactly are we fighting in the ICU?
Well, that brings us to Section 3, the lethal diamond, updating the threat.
Historically, prolonged surgery triggered what was widely known as the lethal triad. This is a vicious, deadly cycle. First, the patient gets cold, hypothermia. Then, their blood turns acidic, acidosis. And because they're cold and acidic, their blood simply stops clotting, which is coagulopathy. Once a bleeding patient enters this downward spiral on the operating table, it is incredibly difficult to reverse. But modern guidelines have actually updated this threat to the lethal diamond by adding a fourth pillar, hypocalcemia. That means low calcium levels are now recognized as a primary killer we have to actively combat.
Here is the kicker. When we give massive blood transfusions, the preservatives in the banked blood can actually strip free calcium right out of the patient's bloodstream. Since calcium is literally required for blood to clot, this makes the coagulopathy way worse. Recognizing this as a diamond means we now aggressively monitor and replace calcium in real time during resuscitation.
Which leads us to Section 4. Damage Control, Resuscitation Updates, Fighting the Diamond.
So how do we systematically fight this? You can't talk about modern DCR without highlighting the landmark Proper trial. It proved that the absolute magic ratio for blood transfusion is 1:1:1. That means giving equal parts plasma, platelets, and packed red blood cells to perfectly mimic real whole blood. In the past, we just pumped patients full of red blood cells to carry oxygen, totally neglecting the clotting factors and platelets needed to actually stop the bleeding. The 1:1:1 ratio treats the coagulopathy right from the very first drop.
Because of this, we no longer pump patients full of watery, crystalloid fluids like standard saline. Instead, we practice what's called permissive hypotension. We intentionally accept a lower blood pressure temporarily until the bleeding is surgically stopped. Think about it. If you use massive amounts of saline to crank their blood pressure up to normal before the surgeon has patched the hole, you will literally pop the fragile, life-saving blood clots right off the injured blood vessels, causing them to bleed to death even faster.
Additionally, we rely on some incredibly powerful pharmacological adjuncts. The massive CRASH-2 trial showed us that the clot-stabilizing drug tranexamic acid, or TXA, is a huge lifesaver, but only if given within a strict 3-hour window from the time of injury. The protocol is a 1-gram bolus followed by a 1-gram infusion, and it essentially prevents the body from prematurely breaking down its own clots. But if you give it after that 3-hour mark, the data shows it can actually cause harm. Timing is absolutely everything in DCR.
This targeted approach extends straight into the pre-hospital setting, where recent 2026 data reveals a really surprising twist. For the last few years, there was this massive push to deliver whole blood directly in the ambulance or the helicopter. However, recent rigorous trials, like the SWIFT trial and the latest meta-analyses, show that while pre-hospital whole blood is incredibly effective, it actually doesn't offer a statistically significant survival benefit over simply using balanced 1:1:1 component therapy out in the field. The major takeaway here? It's less about whether you use whole blood or components, and way more about just starting balanced hemostatic resuscitation as early as humanly possible.
All right, Section 5, Expanding Balanced Resuscitation, the future of DCR.
As we look to the horizon, the new paradigm goes way beyond just replacing lost blood or fixing the lethal diamond. We are now looking at an entirely new wheel of balanced resuscitation targets. We're targeting the whole system. This includes treating endotheliopathy, which is the shedding and destruction of the microscopic lining of your blood vessels. It includes addressing acute trauma-induced inflammation, and even managing the body's stress response, the HPA axis, directly. We're finally realizing that hemorrhagic shock is a total body cellular event. It is not just a plumbing problem.
Ultimately, this means treating hemorrhagic shock will soon rely on real-time biomarker tracking on the scene, rather than just a one-size-fits-all fluid protocol. Trials like Cavalier and BioTroop are paving the way for true precision medicine in trauma. We are rapidly moving toward a future where medics can run a quick blood analysis right in the ambulance, instantly see exactly which specific clotting factors or hormonal pathways are failing in your unique body, and deliver a perfectly tailored resuscitation cocktail right on the spot.
So as we wrap up this explainer, I want to leave you with a fascinating thought to consider. What if the most complex, life-saving resuscitation happens before you even reach the emergency room doors? From that new XABCDE priority, to fighting the lethal diamond, to hyper-precise targeted damage control resuscitation, the boundary of trauma care is pushing further out of the hospital and into the field. Thank you so much for joining me, and I hope this provided a crystal clear look at how we are saving lives today and exactly where we're headed tomorrow.